Thank you, everybody. This is the October meeting for the Informed Prostate Cancer Support Group. Welcome. Thanks for joining us today, whether you're joining us live or watching this in the near future. There we go. I hope you are all dealing sufficiently with the coronavirus. It still is likely that we will not be meeting in person at Sanford Burnham for the rest of the year. But in the meantime, John Tassi is going to be continuing to live stream these meetings on the third Saturday of every month. And we hope that you can attend or watch the videos shortly afterwards. I'd like to thank all of our hosts and volunteers. The Informed Prostate Cancer Support Group principals include Lyle LaRoche, our president, Jean Van Vliet, one of our directors, Bill Manning, director who also does the videography when we are meeting in person, John Tassi, who does double duty as our webmaster and is handling all of the complicated video streaming today and every month. Steve Pendergast does a fantastic job with our newsletter, and Bill Lewis writes up the meeting summaries from the prior months. And myself, I'm Aaron Lamb, the facilitator. This is only my second meeting doing this, so please again bear with me. And of course, we have close to 900 members out there that either join us monthly or have in the past, and rely on us for a lot of information. And it's a remarkable group to be able to present to and use for their experience. And everyone is a volunteer. You can be too. Please do contact Jean if you want to, Jean or Lyle, if you would like to help out in any way. So our support to you includes our website, www.ipcsg.org. That stands for Informed Prostate Cancer Support Group. On that website, you can find a whole wealth of information, including our newsletter and the newsletters from every month in the past. They contain a huge amount of current information on treatment for prostate cancer. And we also provide this monthly video streaming. Perhaps most importantly, for those of you joining us for the first time, is our hotline number, 619-890-8447. If we know that if you've recently been diagnosed, you have a lot of questions on what to do next. And please, contact us on our hotline. Somebody will get back to you very shortly to help you, because we know time is of the essence, and this is a complicated situation that you're entering. But we're here to help you out. So our support group focuses on helping you out there become your own case manager through informing, networking, and caring. We're a group of experienced participants, but note, we are not medical professionals. And so any sharing by any one of our group does not substitute for your medical counsel. We mainly help you answer the questions that you might have and generate more questions for your medical professionals. And we do need your support. We are a 501c3 nonprofit, which means that your donations are tax deductible. We don't have any medical or religious affiliation. And during the coronavirus pandemic, we're still providing the video streaming as opposed to our in-person meetings, but our costs remain very much the same. The significant costs include maintaining the website as well as advertising to help get the word out to new members. So please do make a donation if you can, online via our website, or you can send a check. All of that information again is on the website, so please do check it out. Our meeting next month will be with Dr. Richard Lamb. We are very Happy to have him come and speak again. He's one of our popular speakers. He'll be providing an update on prostate cancer treatment, and that's going to be Saturday, November 21st. But for today, we are lucky to have a couple of the experts on proton therapy here to inform you and answer your questions. Dr. Carl Rossi, MD, radiation oncologist and medical director of the California Proton Treatment Center, has personally treated more than 10,000 prostate cancer patients with proton radiation over the last 26 years, more than any other physician in the entire world. Also today, we have Dr. John Einck, MD, radiation oncologist and professor of radiation medicine and applied sciences. He believes in a team-based approach to patient care. Dr. Einck joined California Proton Cancer Center shortly after the center's opening in 2014. His treatment philosophy emphasizes patient education and encourages everyone to participate in deciding what course of treatment is best for them and their personal goals. Dr. Rossi and Dr. Einck will discuss the advances in proton therapy. We'll have a Q&A. We'd like to have perhaps limit the questions to just 3 to 5 after 3 to 5 questions after Dr. Rossi's first presentation that are hopefully directed towards his content that he presents on. However, we're going to take all further questions, both for Dr. Einck and in general, after both presentations are done, for as long as we either have questions or have time. So on that note, I will, when you do submit a question, please use the Q&A portion of Zoom as opposed to the chat, but I will be monitoring both. And John will also be monitoring Facebook and YouTube, because we have a lot of viewers on various platforms. So Dr. Rossi, please take it away.
Okay, well, thank you, and thank you, Aaron, for the introduction, and good morning to everybody in what is becoming the new normal. Appreciate what you guys are doing and how you're keeping this going during this somewhat interesting time. Let me go ahead and start sharing my screen. I'm going to be doing a 15-20-minute presentation, and then John will be picking it up after that. So give me just a second here. We want to do this, and we're going to want to share that. And you should, hopefully, when this comes into, come on, you should be able to see a slide intro to intensity modulated proton therapy. Is that what's coming across?
Yes, sir.
Yeah. As Aaron mentioned, our facility's been open since 2014, but since the end of 2017, we've been affiliated with UC San Diego Medical Center, in particular the Radiation Oncology Department. And that has been an incredible boon for us in many, many, many ways. We're all quite happy with that affiliation, thankfully. You know, going back, talking about radiation therapy, you got to realize it goes back a long way, over a century. And you have here on the left Henri Becquerel, and on the right is William Röntgen. And these are the gentlemen who discovered both natural radioactivity and X-rays. And this is, 1895, 1896, which sounds like a long time ago, but in many respects, it really wasn't. And like a lot of scientific discoveries, of course, there was much, much, much to be learned. I think fundamentally, it's important to understand how radiation therapy works. And this is true of any radiation. I get patients that come in, I'm sure John does as well, say, well, I don't want radiation treatment, but I want protons. Well, protons are radiation. On the molecular level, the way that radiation kills things is you damage DNA. That is the target. You create either direct or indirect ionization of water molecules or directly hit the DNA. And what you're doing is you're breaking it. So effectively, you are destroying the blueprints of the cell. And again, that is true of protons or X-rays. I mean, there probably are some subtle differences on the atomic level, but from a clinical standpoint, they're essentially the same. That's true of all radiation. This is something which was learned the hard way. So if you look at the history of radiation therapy, it actually goes back to before the turn of the 20th century. And people started using it empirically as a cancer treatment in 1896. And this was based on the observation that, lo and behold, when people received radiation, their skin got red. But there was a lot to be learned. And this picture you see in the background is a monument that's at a hospital in Hamburg, which has over 400 names on it. And these are physicians and physicists who died because of the effects of the radiation that they were studying. So you have the Curie, we have Madame Curie on this monument, and many other early radiologists. We learned the hard way that radiation is a very powerful weapon, both for good and for bad. Some basic tenets of all radiation therapy is that, first of all, as far as we know, if you give a high enough dose, you can kill any living system with it. There certainly are differences in radiation sensitivity among tissues, but there's no such thing as a cell which is truly 100% radiation resistant. What makes radiation feasible as a treatment is that, in general, with a lot of caveats, malignant cells are less able to repair that DNA injury than their normal counterparts, but therefore they're more likely to die, although those differences can be relatively modest. And we don't know, although this is a controversial statement, it remains so, we don't know if there was a threshold dose below which damage does not occur. There probably is, but because of the arguments about it, we've adapted in radiation therapy and in diagnostic radiology and general radiation safety what's called the ALERA principle, which stands for as low as reasonably achievable, meaning that we always strive to give the lowest radiation dose to normal tissue that we can. This is true of all of our modern technologies. We're all trying to do this, whether it's protons, brachytherapy, X-ray therapy, you name it. If you look at the advances we've had in radiation therapy technology over the last 100+ years, they've really all been centered with that idea in mind, that we want to try to limit radiation dose to normal tissue while increasing dose to target. Again, this is true of everything we do. All of these methods, which are good methods, are based upon that premise. And one of the reasons that we have been focusing on physics is that we understand it and can manipulate it a heck of a lot better than we can manipulate radiation biology. So we focus our efforts on the physics of radiation therapy to try to get the best therapeutic gain. Intensity modulated radiation therapy, which is really the standard for external beam radiation these days, is the latest development of modern X-ray therapy. And it requires a lot of different techniques, including 3D reconstructions of what you want to treat, lots of computer support. There are these various different brand names that you hear about, TrueBeam, VMAT, tomotherapy, CyberKnife. These are all variations on IMRT. But IMRT it's been around now about 20 years. It continues to improve, but it was introduced, like all other things in radiation therapy were introduced because the physics were superior to its predecessor. Not at least in the United States, because there were phase 3 studies that said, hey, it's better. It had to be done before this technology was implemented. And if you look at differences, this 3D CRT, 3D conformal radiation therapy, this was the standard of the 1990s when I was doing my residency. What we would do with X-rays, you'd create these nice box-shaped distributions. You'd get a high dose of the target and relatively low doses outside of it. This is with even older IMRT, where you're able to confine that high dose area much more tightly to the target. The downside, of course, being since you're using X-rays, you're always going to have some dose from skin to skin, and that's where probably the single biggest difference between X-ray therapy and proton treatment. And this is what, if you look at now modern X-ray therapy using what's called the volumetric arc treatment, again, you're getting even more tightly confined dose, beautiful high dose areas, really in many respects even tighter high dose areas than we can do currently with protons. But since you're using X-rays, you have this dose bath to normal tissue, which is something we would prefer not to do if we didn't have to do it. When you look at proton plans, which is what you see here on the left, and IMRT plans, when you're treating big irregular shapes, those differences become greater and greater. So here you're treating prostate and pelvis, and in the proton plan, you're able to spare a lot of the pelvic contents that you're going to treat to some degree with IMRT. So in general, when you look at comparative plans, which we do all the time, the larger the shape, the more irregular the target volume, the greater the disparity in normal tissue dose between protons and X-rays. But again, as I said, despite that, IMRT, it's good treatment. It's become the de facto standard for a very good reason. You know, the physics of protons, as I'm going to dig into here in a second, are superior, but the availability remains inferior. That's because of the complexity of the centers. That's changing, as you're going to see. But the real key to make protons, in my opinion, widely adapted is we've got to get the cost of the treatment to the payer to be the same as what they're currently paying for modern X-ray therapy. Protons, well, they're protons. They're subatomic particles. They're actually the most common particle in the universe. They're part of the every atomic nucleus, and everybody that's hearing this talk today and everything that we know of. And in fact, it's the number of protons in the nucleus that determines the atomic number and some of the physical properties of that element mentioned here. They're positively charged, which has a big role in how can we use them in radiation therapy. You can't do a talk on protons without a slide like this. This is William Henry Bragg, who in 1904, I think it's a typo, but 1903, and 1904, whatever, he discovered that when you shot charged subatomic particles into something, they gave a relatively low dose of ionization on the way in until they came near a stop where you get this big spike of dose, which is now called the Bragg peak. And then as the particle, this is occurring because the particle is running out of kinetic energy, it's coming to a stop, the dose at that point drops to zero. Bragg, being a typical underachiever in physics, when he discovered that, he was, at the time, he was a future Nobel laureate in physics. He was a 1915 Nobel Prize winner for developing X-ray crystallography. But again, this goes back over 100 years. I think it's a nice touch that the Australians, which Bragg did his work in Adelaide, the Australians have named their new proton center that they're building, which is this building here in the center, the Bragg Proton Therapy Center. They started construction about 6 months ago. Nice touch. But the real idea of using protons as a medical treatment is courtesy of this gentleman, another underachiever, one of my heroes, Robert R. Wilson. Wilson was the youngest section head at Los Alamos during the Second World War. He did his physics training at Berkeley with a guy named Ernest Lawrence, who had invented the cyclotron. And he wrote a paper in 1946 saying, you know, because of these physical properties of protons, that may make them useful as a cancer treatment because you can spare normal tissue with them. This is a little bit more about Wilson. It mentions the paper here. In later life, he was the founding director of the United States' premier high-energy physics lab, the Fermi National Laboratory in Batavia, Illinois. He was a sculptor. These are some of the sculptures he did, which are at Fermi Lab in front of the headquarters building, which not surprisingly is called Wilson Hall. It's this. He designed it to deliberately look like one of the very famous European cathedrals. Fascinating man. Lived to see all this happen. He died in 2000. So it wasn't long, though, after he came out with this idea that people first tried this. And this is some of the first patients being treated at Lawrence Berkeley. And that's not exactly an ideal clinical setup, as all of us will tell you. And that went on for 30 plus years. It was in 1998 that was the groundbreaking at Loma Linda for the world's first medical proton treatment center. And that one, like most of the ones up until recently, has been designed with one accelerator and multiple treatment rooms. This is actually a schematic of our facility here in San Diego with 5 rooms, three of which have these isocentric entries. Something to realize in radiation therapy, and this is true in protons and true in X-rays, the machines got bigger before they got smaller. This is radiation treatment of the T19 teens. These are Van de Graaff generators that generate megavoltage X-ray beams. You know, these are things that just were big, bulky machines that are now much, much smaller. Another picture there of the kind of distorted person here in the corner for scale. You know, now, of course, you want X-ray therapy. These machines are 1/10 that size. The same thing is happening, thankfully, in the proton world. If you look around the country, most of the centers that are in existence are multi-room, purpose-built facilities, you know, $100 million, $200 million. That, thankfully, is becoming less and less common. There are still some of those being constructed, but most new facilities are much smaller, 1 to 2 room centers. Here's you know, to give you a comparison. This is Varian, one of the many vendors' latest design for a completely functioning 1-room proton center that fits in a tennis court. This is what University of Alabama has, University of Miami, and most of the new centers being built use that type of a footprint. Also, new centers use electromagnetically scanned beams to shape the particle, shape the dose of the target. Think of it as a 3D printer with protons, so you can paint dose in the layers, and you can vary the dose within the layers. It's a very nice way to treat especially large or regular targets. You can change things quickly. You can adapt your plans very well to changing clinical situations. So where we are right now, there's currently 37 operating centers in the United States, and another close to another 100 around the world. 2 existing centers, University of Texas, MD Anderson, University of Florida, have expanded their operations by building new facilities next to their existing facilities. Everybody is using pencil beam scanning if they can, or they're retrofitting it. And there's currently something like 18 centers under construction or in planning in the US, with the cost now coming down dramatically, where a single room center is still not inexpensive at 25 million, but it's about 1/10 of what it was just a decade ago. If you look at a map of their locations, most of these centers in the US are distributed in the Midwest and the East, Florida in particular, and along the Northeast corridor. There's still only 4 operating in the Western US. So this is University of Utah, which should be operational relatively soon, week number 5. When we plan prostate cancer treatment with protons, we use the same techniques that we do with x-rays. It really depends upon imaging and mapping the target. Again, this is true of protons, IMRT, brachy, you name it. In the proton world, we do a lot of CT and MR, which we then fuse together because they both give you different pieces of information that you need to treat. The CT gives you tissue density, which is important to know how to stop the particles. The MR gives you a much better idea of prostate anatomy. It lets you see things you may want to hit harder, like dominant intraprostatic nodules with dominant diseases. It lets you also see structures that you want to avoid as best you can, neurovascular bundle, penile bulb, etc. If you're just looking at CT only, here's an example. Well, here's the prostate. Yeah, you can see it, but you really can't tell any internal delineations within it. You know, is there disease here, disease here? Where does the prostate end and neurovascular bundles begin? Can be tough to tell. If you do a T2 weighted MR, same patient, you can see the entire gland. You can see this nice dominant nodule in the peripheral zone just begging for some extra dose. And this is when we would treat patients with rectal balloons, which have really fallen into disuse because of the development of hydrogel, which is something that Dr. Einck has placed 250, 300 by now. We do a lot of them both at the Proton Center and over at the university. That's your dominant target. This is also what MRI shows you. If you're looking at a diffusion weighted image, parent diffusion, you can get an idea of where that disease is, and you just target it. You make that part of your target. And that's how we do our planning. Sometimes we're relaxing at home, but here again, you've got your target, you're giving a high dose to the prostate, you're giving the highest dose to that area where there's the greatest amount of disease. And what you're not doing is treating stuff anterior and posterior to the gland. You also get a good idea here of what that hydrogel can do in terms of pushing the rectum way back. That's looking at it in the sagittal view. As I mentioned earlier, we are using spacer on virtually all patients who are candidates for it. It's done a wonderful job of reducing the incidence of rectal bleeding, which used to occur in 20 to 25% of the patients down to less than 5% now. So let's talk about some recently published data, and then I'll wrap this up. There's been a fair amount coming out in the last couple of years. This is just some samples of it. University of Florida has done some cohort studies, and again, these are not randomized prospectively, but it's trying to match up patients based upon their other clinical characteristics. And this was looking at patients they treated using what we would consider now to be old style proton therapy, passive scatter, back in the 2006, 2007 timeframe, compared to similar patients who got IMRT. The radiation doses were about the same, the follow-up was about the same, and hormone therapy was used in both groups, with it being used somewhat more in IMRT. So first of all, overall survival of the patients longer likely to be alive or not, no difference. And I wouldn't expect there to be, for the patients who had to work for, the old patients are actually well older than 75. Radiation is radiation. The cancer cells are seeing the same dose. So there's not going to be any difference in biologic effect. They did see, though, a little bit of a difference. These are both good numbers either way in the proton patients who are a little bit more likely to be alive at this time point than those who received IMRT. It was statistically significant, and it's still pretty good either way, 97 versus 90, almost 92%. That was somewhat seen in the intermediate risk patients and the high risk patients. There was no difference. Toxicity, there was a difference there as well. Despite the fact that proton patients got a little higher radiation dose, they seemed to have a lower incidence of what we consider to be moderate grade 3, which is significant GU toxicity. We're talking about well under 1% versus 1% in GI, and same thing in the patients for GU urinary issues. Their conclusion was that despite the fact that the proton patients were not getting as much ADT, and despite the fact they got a higher dose, their freedom from relapse tended to be lower in some of the, but not all of the patients that were treated in favor of protons. Northwestern has put out data looking at a big, one of the things we kind of love to hate. These are these big Medicare database data mines because they got all sorts of caveats and things you got to worry about. But they tried to look at patients who had received proton treatment, again, back in the same time frame, matched to IMRT. Overall survival difference they did see in the intermediate risk patients. And the reason for that was because they saw fewer second malignancies in the proton patients. And that's, we're going to be talking about that again in the next couple of slides, but that was the reason there was a difference in overall survival. The patients who were getting protons had a somewhat less likely incidence of getting a second cancer, 6 versus 10%. And those were pelvic malignancies and leukemias, and these things tend to be hard to treat and can be deadly. This is another paper based upon what's called a registry trial that's ongoing. We were looking at patients who had advanced disease where you had to treat very large fields. And this is acute toxicity, not late, but during treatment and shortly thereafter. And what we found is that the patients who were receiving protons when we were treating their pelvis, they had less acute gastrointestinal toxicity than patients who received IMRT. And again, that's not too surprising because of the difference in dose to normal tissue. Second cancers, have been a couple of papers that have come out on this in the last couple of months. This is from the University of Pennsylvania. It was published in Cancer, I think, in March. It's a big comparison, again, where they're looking at 3D conformal radiotherapy, the 1990 standard, IMRT, or protons. Big database mine, lots and lots of analysis, number crunching. They looked at something like over 9 million patients with a median follow-up of just over 5 years. And what they found, first of all, is that with the 2 different types of X-ray therapy, there was no difference in second cancer rates between these two. It was low, but there was no difference. But kind of surprised us because there was some thought that IMRT could be a little higher, but it wasn't, which is good. However, with proton patients, they had an incidence of second cancer that was less than 1/3 the rate that we were seeing with X-ray therapy. That was consistent across all age groups, and it was consistent in all disease sites except for lung cancer. It included head and neck cancers, prostate and breast cancer. And they did a scatter plot of that, and you can see that the risk of second cancers was less in all these things, with the exception of lung cancer patients where there was a slightly favoring IMRT. So their findings, first of all, because of the number of people that were analyzed, this is, there's a lot of data in there, and it tends to make it a pretty robust analysis. But I think the most important thing is that when you look at the regulations we currently use for radiation therapy safety and the mathematical models, they predicted this. They predicted this 15, 20 years ago from some work that was done at the Paul Scherrer Institute. And this data is consistent with those modeling studies. And surprise, surprise, the less radiation we give to healthy tissue, the fewer second cancers that we see. These numbers, remember, the absolute number is small. It's not like, we're talking about low single digits getting second cancers, but still it's important. So conclusions, and I'll wrap this up. Particle therapy has been around a long time. It's not a boutique treatment. The first prostate cancer patient was actually treated at Harvard cyclotron in 1977. We're learning how to use it in more effective ways. We're still learning how to use some of the commonly adapted and employed tools in proton therapy that we use in X-ray therapy. And again, I think the real key to getting proton therapy to take off is going to be to get the cost to the payer to where it's equivalent to what they're paying for other modern, very effective, high technology treatment. We do see some lower incidence of GI toxicity, less bone marrow suppression. There's a paper from Florida showing less testosterone suppression, and several papers now showing a lower incidence of radiation-induced second cancers. And at that point, that's the end of my presentation. So I'm going to stop the screen share and see if there are just a couple of questions. So let me go to Q&A.
Yeah, I think we have a couple questions there. Can you see the Q&A?
I can.
Okay.
I can. So the first one is proton therapy ever appropriate for SRT? I'm assuming that means SBRT, stereotactic radiotherapy. Yes, the answer is definitely yes. In fact, the history of stereotactic radiosurgery going back to the 1960s, it was first done with particles. before Dr. Lexell invented the Gamma knife. I've treated some 40-odd gentlemen with SBRT for low-risk prostate cancer, 8 gray and 5 fractions. Oh, the salvage radiation therapy. Anyway, I just have not been happy with what I've seen with the toxicity of SBRT in prostate cancer. I'll leave it at that. Urinary toxicity. Salvage radiation therapy, yes. You can use protons for salvage treatment. You can use interstitial implant, either temporary or permanent. People have done salvage radiation therapy with IMRT and with CyberKnife. There is a lot to still be learned about salvage radiation therapy, and there are a lot of factors that determine its risk. You certainly have to consider any salvage radiation treatment more, have to be riskier than the original treatment because of the unknowns in terms of disease, the amount of repair there had been from the prior treatment. Second question would be, do we use the balloon? Not very much, and this is because of the hydrogel. So the balloon does stabilize the prostate. You actually see the same thing with the gel installation where you see very little movement of the gland with respiration. And the nice thing about the hydrogel is you're actually moving that sensitive organ away from the radiation field. So the best way to protect something is simply to push it away from the target. You still also, when you do your treatment planning, and this is true of all radiation therapy, you build a safety margin into the plan. For a prostate, we usually use 3 to 5 millimeters, depending upon which direction you're measuring as your safety margin. So target motion in protons is more of an issue with highly mobile targets like the lung, and where we have to do other things to adjust for that. In the prostate itself, with either the balloon or the hydrogel, that's not really an issue. Why do patients get skin burns from proton radiation to bones near the skin? It's not the fact that the bone is near the skin, it's the fact that we're having to treat a structure which is close to the skin surface. And this is where there's a difference in the way protons interact with tissue than X-rays. When you treat a patient with X-rays, megavoltage X-rays, there's skin sparing because there's actually a buildup of radiation dose as the X-ray beam enters the skin. The highest dose of a megavoltage X-ray beam is typically at a depth of about 1.5 centimeters, so that's well below the skin surface. In proton therapy, if you're treating something which is close to the skin, which is often the case if you're treating, say, ribs or even treating the whole breast, we have to make sure that the dose, because you want the Bragg peak in that target, which is close to the skin surface, you have a higher skin dose, definitely. We've seen this in the breast patients. We've seen it in other patients where you're treating close to the skin surface. So that is something we have to take into account in the planning process. We do have some ways to try to minimize the skin dose, but many times it's just a factor of trying to treat a structure which is close to the surface of the skin. If you want to get 100% dose on that structure, you end up getting a high dose to the skin. Okay, let me mute myself. I'm happy to hand this over to Dr. Einck.
Yeah, we'll finish off that last question after at the end of Dr. Einck's presentation. So please take it away, Doctor.
Thank you so much for inviting me back to speak to the group. I love speaking to this group. You guys are so, number one, the attendance is great. Those of you that have been through prostate cancer treatment and are survivors, or those of you living with prostate cancer, I love it that you take it upon yourselves to take that experience and try to pass that down to those folks that are newly diagnosed and really trying to make decisions about their treatment. So I really applaud you guys for the service that you provide. It's a little bit intimidating talking in front of the world expert in prostate cancer proton therapy. So I'm going to ask Dr. Rossi to jump in if he has any additions or corrections to what I'm saying. As Dr. Rossi said, for about the last 4 years, I think, California Protons has been affiliated with UC San Diego Health. I actually work for UC San Diego, but I spend a day a week at the Proton Center. And it's very interesting. I'm the director of the residency program training doctors in radiation therapy at UCSD. And when I come out of a room with a patient after recommending something, the residents are very savvy and they will call me on virtually anything and ask me, why did you recommend protons for this patient? Why did you recommend brachytherapy for that patient? And I really have to have good reasons for doing everything that I do, given that we do provide IMRT, brachytherapy, and protons to our patients. So I've spent a lot of time over the last several years sort of clarifying in my own mind which situations where I think proton therapy is better than IMRT. And I want to talk a little bit about more about those situations today. So let's start with the case. We have this 56-year-old guy. Actually, this guy looks a bit older than 56, but let's call him 56. His PSA presented as a PSA of 12.3, and his doctor felt a nodule in the right side of his prostate. He was found on biopsy to have Gleason 8, 4+4 adenocarcinoma, with virtually almost every core on the right side was involved and no cores on the left side. And his prostate's pretty small. It's only 25 cc's. So many of you are familiar. I've showed this slide at previous talks with how, as doctors that treat prostate cancer, we're lumpers. We like to lump patients into categories, and that's what tells us how aggressively to treat them. So this guy would squarely be lumped into the high-risk category because he's Gleason score of 8 to 10, which is his is 8, which is relatively high. This is his MRI scan. Actually, I don't know that this projects that well, but you see this dark spot in what this would be the right side of his prostate. The prostate should be sort of this lighter gray color. And when you see a big dark spot in the periphery of one of the sides, that's prostate cancer. And this spot is not only in the prostate, it's actually bulging outside of the prostate. And almost certainly he has some extracapsular extension here, in addition to his Gleason 8 prostate cancer. But his lymph nodes were normal. His seminal vesicles were normal. So what are we going to recommend to him? How are we going to counsel this patient regarding treatment options? Should he have surgery? Well, I think those of you that have heard me speak at this meeting know that I've told you many times that in essence, surgery and radiation have very, very similar outcomes. Survival, long-term survival is different, but the morbidity, the side effects, the what might happen afterwards is much different. And in this patient, his risk of needing more treatment after surgery is going to be higher because he's got that extracapsular extension, and he's almost certainly going to need radiation after surgery anyway. So the answer to that, in my mind, is no, although others may disagree with that. But among radiation options, is there one option that's better than others? Now, this is what the NCCN says. NCCN is a group of experts that gets together, and they're surgeons, they're urologists, they're medical oncologists and radiation oncologists, and they take a patient with high-risk disease, and based on their expected survival, let's say they've had a stroke last year, or they've had a serious heart attack and aren't very healthy, and we don't think they're going to be 5-year survivors, well, then we're going to be a little gentler with our treatment options. But in a patient, like most patients we see, where we can predict that they're almost certainly going to be alive relative to their medical condition over 5 years, the options that the experts say are the best are external beam radiation therapy with ADT, external beam radiation therapy with brachytherapy and ADT, or radical prostatectomy with lymph node dissection. They also allow, in the footnotes of the NCCN, they say that this EBRT can be protons, it can be IMRT, but whatever we do, it should be high dose. So let's talk a little bit about radiation. So I've already mentioned several radiation options, but in my mind, when we're talking about external beam radiation, the choice for me is either proton beam or photon beam. And this is just a picture of one of the gantries in the Proton Center, showing that the machine is able to rotate 360 degrees around the patient. The patient is on this table here, and but the machine, while it's delivering the proton therapy, is stationary in one position. Some of you are familiar with VMAT or RapidArc, or there are a number of brand names for these different kinds of IMRT, but this is the photon machine with a little schematic here just showing that Usually we use VMAT, where the machine actually rotates 360 degrees around the patient. And brachytherapy is just totally different than any of these other options. It's a procedure where we use ultrasound in the rectum here, and we use needles through the skin over the perineal area directly into the prostate to either implant permanent radioactive seeds or to the needle stay in for a little bit longer, and we do temporary needle implant with high dose rate brachytherapy. So we have all these options, but I think most people would say, and I think it's important to realize, that these are all just similar tools that do virtually the same thing. All these three tools just are made to hit something, but the things that they're made to hit and the collateral damage that they might cause are totally different. So some are better for certain uses, and I think radiation is no different. For some reason, I can't advance. Let's see. Okay, so which treatment is best for a particular patient? Well, it depends on the goals of the patient. I assume that everyone wants to cure the cancer and have no collateral damage. But for some people, maintaining sexual function might be a bigger priority for them if they're sexually active, have good function before they start. Clearly, if a patient is not having good sexual function, and that's going to become less of a priority. And patients want to have no urinary leakage, I'm sure, as well. And sometimes they really want convenience. Brachytherapy is done in a single day, and then you're done with your entire treatment. Whereas external beam radiation therapy options can be anywhere from 5 treatments, like Dr. Rossi talked about with stereotactic radiation, or up to 39 treatments, which is a common regimen for IMRT or proton therapy. So for this guy, I recommended 12 months of ADT. I'm not going to get into ADT too much, but I'll just say that in patients with high-grade prostate cancer, Gleason 8 to 10, ADT not only improves their cure rate as measured by their PSA, but it also improves their survival from prostate cancer. So it's a very important part of their treatment when using radiation. I recommended 5 weeks of proton therapy. That's because I knew this guy's lymph nodes were at risk. And I'll explain in a few minutes why I prefer proton therapy when I'm treating nodes. Dr. Rossi's already talked about a bit of this, and I'll refer to that. And then followed by a seed implant. And again, this is not a brachytherapy talk. I've talked about brachytherapy with some of you in the past. But just to suffice it to say that the higher doses of radiation that we can give, the more likely we are to cure the prostate cancer. There are methods with proton therapy to escalate dose to the area where the prostate cancer is, as Dr. Rossi pointed out. But brachytherapy really escalates dose to the entire prostate gland. And the reason we want to do that, these are results from UCSD in the treatment of high-risk patients. We had 183 patients. Over 90% had ADT, but that's because I feel strongly that these patients, that ADT has a survival benefit for these patients. And not all high-risk patients do the same. This is called a survival curve. So at time 0, this is when they start their treatment, 100% of patients are considered relapse-free. They haven't even started, so they couldn't have relapsed yet. But then as time goes on, we get out to 20 months, we get out to 40 months. Some of these patients are now relapsing. Their PSAs are going up, and we find that they still have prostate cancer. These patients on the upper curve that have over an 80% and even 85% long-term relapse-free survival, those are patients with just one risk factor. So they might have Gleason 8 disease, but everything else about them is favorable. It's these patients on the lower curve that we need to do better with. They're at 60 months, at 5 years, they do statistically worse than the patients on this upper curve. And so these are the patients I recommend something else for. That could be adding brachytherapy to their treatment regimen, or it could be adding proton therapy with a simultaneous boost to the area of the nodule. So this is the reason we add extra things on top of just general basic IMRT. So let's talk a little bit why I recommended 5 weeks of proton therapy. I could have easily done this with 5 weeks of IMRT for this patient, followed by a seed implant boost. But I want to show you, Dr. Rossi already went over the Bragg peak, so I won't belabor that point. And to say that not all proton beams are the same, he talked about the pencil beam capabilities of IMPT and how we have the ability with really irregular targets like lymph nodes to sculpt the dose around the lymph nodes, delivering very little dose to the surrounding tissues like the small intestine, the bladder, and the prostate. We can even give different parts of the prostate different doses of radiation, as Dr. Rossi mentioned. So these are 4 situations where I prefer protons for the treatment of my patients. One is when I'm treating lymph nodes. And I'll talk about that in a minute. The second is when doing salvage radiation. Salvage radiation targets are often much more irregular than just a round prostate gland. And as Dr. Rossi pointed out, these are patients that have already had surgery. They're healing up from surgery. They're at higher risk for developing complications because the more treatments we add to a patient, the more likely they are to have a complication. I prefer protons in younger patients, and I didn't realize Dr. Rossi was going to show that excellent data about second malignancy risk. But in younger patients, and I consider younger patients under 60, I'm sorry about you patients out there over 60, but I consider under 60, I really don't want to treat these guys with IMRT. They've got 25-year life expectancy, and they're not unlikely to see some of the long-term effects. And then the last one I think is critical. I prefer protons, not only prefer, but I try to demand from insurance companies that they approve protons for patients who require re-irradiation, or at least radiation close to where they've previously been radiated. So in terms of lymph nodes, this is an intensity modulated proton plan. And I'll tell you, the red here is the 100% dose. That's the dose that I've prescribed to the lymph nodes. The lymph nodes tend to sit along the sides of the pelvic sidewalls, and they're on both sides. So we have to find a way to treat this structure and not get dosed to all this stuff in between. There's all this bowel here, there's bladder here. And so that's a tricky thing to do. With IMRT, we can give virtually the same treatment to those lymph nodes. I can get my 100% dose to the lymph nodes, but this red curve here, all of the tissue within this red is getting 50% of my prescription dose. That's the majority. This dark thing is this patient's bladder. That's the majority of this patient's bladder. In fact, it's the majority of this patient's pelvis. And I point out the 50% isodose curve is this dark blue one here. And with protons, it's barely larger than the target volume of the lymph nodes. So we're not getting all this dose that's spread out to the pelvis with protons. Dr. Rossi showed the one study looking at acute GI toxicity. That basically means diarrhea, cramps, rectal issues during treatment. The dose here in the center of the proton plan is virtually 0. This patient's small intestine is getting very little radiation. And I will tell you, in 5 years at the Proton Center, I have never seen a patient receiving whole pelvis radiation like this who's had diarrhea from their treatment. Whereas this is a common occurrence with IMRT. It's about 20% of patients. So one reason I prefer protons for treating pelvis. This is a pretty irregular prostate gland with seminal vesicles that stick way back here. So the protons are much better able to sculpt dose to this irregular structure. With the VMAT plan, again, this is the 50% dose coming way out here. And you can see the 30% is this green dose, really affecting nearly the patient's whole pelvis. This is a patient having salvage radiation. And I think one of the things, at the Proton Center, we're very accustomed to rectal balloon. Dr. Rossi said we're using much less for patients who still have a prostate. But in post-prostatectomy patients who've had their PSA go up after surgery, we use the rectal balloon, and it really immobilizes all the tissues here. So I can treat, this is a little bit of the patient's bladder that now lives where his prostate gland used to live, and I can treat very tight margins around this with the rectal balloon. Up higher in this patient's case, and in most post-prostatectomy patients' case, where if they had seminal vesicle involvement, the shape of the structure is much more irregular, where I think protons do a superior job. The other thing that I think both Dr. Rossi and I do in these patients who have failed prostatectomy and we're going to give them radiation is it's very common that we treat the lymph nodes in these patients as well. So again, I'm going to prefer protons in those patients. So I've gone through this, less scattered, low dose to bladder, rectum, and other tissues. And then the third area I prefer proton therapy is in young men. Dr. Rossi went through these studies quite nicely, but in both children and adults, there have now been evidence of a reduction in long-term second malignancy risk with protons compared to photons. The risk is not that high with either. So it doesn't mean IMRT is an inappropriate treatment for these patients. But like I say, in these younger men, I tend to prefer proton therapy because I know that if I can, as Dr. Rossi pointed out, the ALERA principle, if I can give a dose as low as reasonably achievable in these patients, I should do that. And then finally, I have a couple examples of patients I've treated recently at the Proton Center who've had prior radiation therapy, and then they've recurred. Treatment with IMPT, intensity modulated proton therapy, deposits dose more precisely into structures where the surrounding normal tissues have been previously treated. It's easier to keep radiation dose out of those areas. This is an example of a patient who had prior prostatectomy, had salvage radiation therapy to the prostatectomy bed years ago. So these clips are the prostatectomy bed. This is how close to the area of recurrence that he had his prior radiation. And in fact, there's a little loop of small intestine right here next to some of these clips. I will say in this patient, it would have been impossible for me to use IMRT without spreading dose into these areas and without damaging this area of small intestine. So this is a guy that recurred in a perirectal node. He had a PSMA PET scan that showed this was the only site of cancer in his body. So we treated him with proton beam stereotactic treatment, 5 fractions. The jury's still out on how well he's going to do. My point is, I could not have done this treatment any other way. And next is a 55-year-old gentleman who also had prostatectomy years ago. PSA began to rise, had salvage radiation to the prostate fossa, and then on PSMA PET, he developed lymph node disease. So again, he had further radiation with IMRT to his pelvic nodes. Unfortunately, that didn't work either. His PSA began to rise again, and a repeat PSMA PET. This is a really noisy picture. You can recognize this is a human body here. Things that are bright here are things that are supposed to be bright. Liver, blood vessel, bowel, but he's got these 2 tiny little spots here at the tip of the arrow. These are the only 2 abnormal spots in his body. These are lymph nodes, and he's recurred right above. His previous radiation was down here, and he's recurred right above that area. These are the amazing things I can do with IMPT for these patients. I treated both of these lymph nodes. You don't see dose spread out all around this guy's abdomen. You see very tight dose confined to the location of these lymph nodes. So I told you his PSA was 0.8, and 6 weeks after treatment, 0.3. So I think he's well on his way to a really nice result. This goes along with, and I think this could be is going to be a talk in itself to you guys in the future, the treatment of patients who have just a couple of sites of metastatic disease. We now know that that patients with 5 or fewer in some studies, 3 or fewer in other studies, benefit from actually zapping those sites with radiation. They're off hormone therapy for longer. That may not result in a long-term cure, but it improves these patients' quality of life. And this guy is still off of hormone therapy with the PSA that's going down instead of going up. So much of the choice of which treatment to choose is based on avoiding side effects, but not really curing the cancer better. Dr. Rossi showed you some evidence that there are ways of getting higher relapse-free survival and survival rates. But normally we think of these different options as ways of avoiding side effects better. But we have another way to reduce side effects. It's called SpaceOAR. So I just want to spend a couple minutes on that, since virtually, as Dr. Rossi pointed out, almost all of our patients at the Proton Center are being treated with SpaceOAR. This is a procedure using ultrasound guidance. Excuse me, it looks kind of like the brachytherapy picture I showed you. But we actually place a needle through the skin over the bottom into the space between the prostate and the rectum and inject a hydrogel material that's stable for 3 months. Here's an example of sort of a schematic of prostate radiation, where we're not only treating the prostate, we're treating a rim of normal radiation around the edges, of normal tissue around the edges. With SpaceOAR, we virtually push the rectum completely out of that area. Sorry. This is what it looks like on MRI. SpaceOAR is right here, dramatically pushing the rectum back away from the back of the prostate. And this is the 100% dose of radiation, this red curve being given with protons. Virtually, the radiation's down here around less than 70% of the prescription dose. So this is a patient that's not going to get rectal damage from his proton therapy. So there was a large randomized trial that proved the effectiveness of SpaceOAR. There was literally no grade 3 rectal toxicity, which means rectal bleeding that required treatment in the SpaceOAR patients. There was 5% risk of rectal bleeding in the no SpaceOAR patients. But surprisingly, we're seeing other things from SpaceOAR. SpaceOAR is actually, in some patients, pushing the penile bulb farther away from the radiation as well. So the study was not geared to look at this, but patients filled out all kinds of quality of life surveys before and after treatment. And we're seeing improvement of preservation of sexual function in SpaceOAR patients. 66.7% of those patients who were able to have sex before SpaceOAR were still having sex. This is 40 months later, versus 37% in the group that didn't have SpaceOAR. It also improved urinary and bowel quality of life. So we think of SpaceOAR to push the rectum away, but we get all of these side benefits from it as well. So in conclusion, choice of treatment really does depend on a patient's own unique goals. And your goals might be totally different than the next patient that I see. Different forms of radiation are essentially different shaped tools for accomplishing the same goal. There are clinical situations in our patients where protons are preferred. But consider SpaceOAR with radiation for early stage prostate cancer. It really does make a difference. And I don't work for the SpaceOAR company. I just see the results of our treatment after doing SpaceOAR. Thank you.
Great presentation, guys. Thanks so much. That's quite the wealth of information. And it's certainly making me think back to 3 years ago when I only just heard about Proton about a week before my surgery, and rushed to get an appointment with Dr. Rossi, which I actually then canceled, and I'm really regretting that now. Yeah, that sounds like fantastic results. We have a couple questions on the Q&A. Actually, we're up to 5 questions. The first one is, could you explain proton beam overshoot?
Maybe I'll throw this one to Dr. Rossi, because I don't really understand
Yeah,
what overshoot is.
I think what this gentleman is referring to is what we call range uncertainty. And this has to do with a bit of uncertainty over where the particles are actually coming to stop. If you think back to that Bragg peak, the point at which the particles are stopping is dependent upon the density of the material they're going through. So that determines how deep they will penetrate and where the peak is going to lie. The way that we currently determine that in our planning process is we use tissue density that's obtained from CT scan to figure out, to convert that tissue density to what's called proton stopping power. Now, there's a couple percent of uncertainty in that. And typically, specifically, we figure about 3 to 3.5% uncertainty in tissue density. So what that means is that when we're doing a treatment plan, and this is true of everything we do in protons, we'll do a plan, for example, where we'll assume that the particle range may be 3.5% less or more than nominal. So if you're talking about treating a target, say 20 centimeters deep, you're looking at most about a 7 millimeter variation in range. And we make sure that with our plans and as part of the planning process, we encompass the target with the worst case. So when I'm looking at a proton plan, and when Dr. Einck's looking at a proton plan, we're actually looking at a composite of 12 plans that have various levels of range uncertainty and also what we call positional uncertainty, patient position. So it's a factor we have to take into account as part of the planning process. Again, we're talking about 3 to 3.5%. It's not a huge thing. And like many things in science and medicine, there are methods being developed to reduce it. So if you look at the latest iteration of Varian's planning system for proton centers, it will allow us to use what's called a dual energy CAT scan to reduce range uncertainty. That's one way to do it. Another way is to do what's called, actually use proton CT. You can do a CT scan with protons. It's much less radiation dose than with x-rays. And then you're scanning with measuring the same particle you're going to treat with. So for the time being, it's something we have to take into account when we plan, but we're talking about a very minimal difference, 3 to 3.5% difference assumption in where the particles are stopping.
Excellent.
So, next question is, so a post-RP patient was T2N1, Gleason 9, Decipher 0.78 and 14 months post-op with almost total incontinence and ED recovery, whose PSA has gradually risen from 0.01 to 0.13, is just starting ADT for 2 months. Would a 30-day IMRT therapy be the same risk toxicity as proton beam therapy for salvage radiation? Well, I think this patient falls under, it doesn't say whether the margins are positive or negative. It doesn't really matter here, I don't think. I think this patient, because the nodes were positive, this patient falls under the category of someone who's going to need both their lymph nodes treated and radiation to the prostatic fossa. And when, like I pointed out, I think there is reason to think that proton therapy is going to be better tolerated in this patient who requires lymph node treatment. Of course, it would require a rectal balloon, and yeah, I think probably not 30 days of IMRT, more like 35 days of either proton therapy or IMRT. Long term, I don't know that there's much evidence that the two therapies are dramatically different, but I can tell you that there's a lower chance of the patient getting diarrhea during proton therapy, and which to me tells me we're treating less of the small intestine and makes it a good idea. I will throw in there, though, if the patient doesn't have insurance that covers proton therapy, I think that's more of a complicated discussion. And I think the value is in the eye of the beholder, I think, and whether it's worth the amount of money that proton therapy is going to cost if you're going outside of your insurance to get it. I think that's only something that you can decide. But let's say all things being equal, the patient has insurance that covers proton therapy. I would prefer protons in this patient.
Great.
Next question. In past years, I've heard several doctors say that whack-a-mole cannot work in cases in which prostate cancer recurs, especially outside of the immediate area of the pelvis. Can modern proton therapy improve the chances that whack-a-mole can work? By whack-a-mole, I think you're referring to the concept of the treatment of oligometastatic prostate cancer. That means the cancer is metastatic, but it's metastatic in only a few sites. And it does have value to treat those few sites with whatever kind of radiation you want to. We could do that with stereotactic body radiation therapy using an IMRT platform, or we could do that with stereotactic body proton therapy at the Proton Center. And a lot of it depends, I don't think that either one works better than the other, but I think that if the patients had prior treatment, like I mentioned, radiation close to the area where we have to treat, the value of this kind of therapy is delaying the time at which this patient might need hormone therapy again. I will admit I'm not so aware of the evidence as to how many long-term cures there are 5 years after this kind of therapy. Maybe Dr. Rossi has a better idea, but really the value of it is preventing that patient from needing another form of treatment right away, and it delays other forms of therapy. And getting someone off hormone therapy for a year or two, as many of you know out there, is of great value to many patients.
Precisely what Dr. Einck said. Yeah, the chance of cure is unfortunately low. I mean, you're talking about at most, best I've ever seen in some literature, about 25, 30%. And those are situations I think which are relatively unique. I think that by far the more significant benefit is delaying ADT. You're suppressing the progression of the cancer. You're letting the patients have a higher quality of life. And that is, as anybody who's been on ADT, or as physicians who prescribe ADT, none of us like doing it. Getting people off of that and having them stay off of it for a long time span is a win. It in some respects is every bit as much of a win in my mind as if we're able to say, "Yep, you're cured, and don't worry about it. It's not going to come back."
Good to know.
This is a really good question. Under what conditions do you prefer IMRT therapy over proton? I don't have a great answer for it, but it is a really good question, and I think deserves to be answered. I would venture to say that there are no cases that I know of where protons are going to be worse than IMRT for a particular condition or problem. But I will tell you there are situations where I don't know that protons are going to be any better than IMRT, and they have to do with early stage patients with disease confined to their prostate that don't require lymph node treatment. And for those patients, I think that patients can have proton therapy for that. I think they can have IMRT for that. And I consider them essentially equivalent, although Dr. Rossi just showed you some data to suggest that, we still have to consider that there may be some advantages to proton therapy. And I think this is a good one too. We've had Dr. Munt, Dr. McKay give us presentations. Now you, I think, work with UCSD. I'm confused. What's the difference between all of you? Whom should I go to? I think Dr. Rossi will agree that the line is getting more and more blurred between, we consider all of us working together, but I think Dr. Rossi is part of the Proton Center group, and I am part of the UCSD group who happens to find protons a valuable tool that I should offer some of my patients, so I spend time over there. Any radiation oncologist in San Diego, I think, and correct me if I'm wrong, Carl, can get privileges to treat their patients at the Proton Center. So I'm kind of like that in that I'm paid by UCSD. I don't get more money if I treat a patient at the Proton Center. So I think you always have to think of medicine as a business and ask the question of whether there are any competing interests behind that financially. But in this case, with any of us, there are not. And but as I say, the line is getting more and more confusing. Dr. Rossi is a professor at UCSD, as I am, but who gives us our salary is different.
Yeah, that is a good question, because I know that for me, when I had salvage radiation, the question of proton therapy didn't really come up, although I was with UCSD. Do most other oncologists, whether radiation oncologists or non-radiation oncologists at UCSD or elsewhere, are they as open to proton therapy?
That's a really good question.
Yeah.
I know it's kind of a generalization, but
Yeah.
like, would you, if I were a typical patient going in to talk to a radiation oncologist, are they as comfortable referring to proton therapy?
I would guess that there are many radiation oncologists, if you meet with them, that aren't going to immediately talk about proton therapy with you as a treatment option. I don't think they're trying to keep a secret from you.
Mm-hmm.
I think that there are cases where the data in the literature just does not tell us that one is specifically better than the other. And if there were, and protons were clearly better for what you have, then I do think that's a mistake and someone's trying to keep a secret from you. But I think in most cases, they're recommending what they know how to use for your treatment.
Yeah. It does sound, though, that for new patients going into this, that it might be very important to have a second opinion, especially with doctors such as yourself associated with the Proton Center. People who are more experienced with PVT.
I absolutely agree with what you just said. I think that you could pretty much say for any condition, a second opinion is a good idea. And if you go to a physician and they discourage you from getting a second opinion, I think that should raise some suspicion.
Yeah, good to know.
I also think that one of the many benefits of us being affiliated with the Proton Center at UC San Diego is that, John mentioned he's the director of residency education. We get to have the UC San Diego radiation oncology residents come through and spend time at the Proton Center, which effectively, to me, it demystifies it, because like anything, there are a lot of misconceptions out there about various technologies, including this one. And when people actually get to see what it can and cannot do, they feel a lot more comfortable with discussing it and potentially recommending it, as opposed to just being dismissive of it, which you find that with any technology. Oh, it's no good, etc. It was so great we have it here. All these other throw out canards that people use. But it's great to be able to show the physicians in training who are going to be out there in the not too distant future, hey, this is where it's good, this is where it's equal, this is where it may be inferior, but at least you have the knowledge base now to discuss it intelligibly and not just based upon some anecdote you may have heard or read.
And it's interesting, they actually seek out experience with protons nowadays because they know that in all likelihood they're going to be living in a metropolitan area that either has a proton center or they're going to be working in affiliation with a proton center. So they're going to need to know these things. So I'm glad we're able to provide that.
Great.
Next question, why do women get skin radiation burns with IMRT treatment for breast cancer? That's a good question. Let me just say that the target is different with women with breast cancer, particularly women who've had a mastectomy and need to have radiation after mastectomy. It's the skin we're trying to treat. So Dr. Rossi mentioned that radiation is skin sparing, and proton therapy is to some extent as well when we're treating something deep in the body. We don't try to give the skin dose. But with breast cancer, we want the skin to get radiation. We take pains to make sure it turns red. So it's part of the target of the radiation beam, and that's why it turns red. So it's all difference in recurrence patterns and what we need to treat. Next question, successive proton therapy to bone lesions in patients with whom ADT and Zytiga do not stop the formation of more bone lesions, delays the time before chemotherapy is needed and stops bone lesion pain. Is that a question or a statement?
Seems like more of the latter. I mean, that certainly is the goal, of course, doing all treatment of all of the metastatic disease.
Yeah, Larry has a couple other questions here too. I know that Larry is quite well read on a lot of the treatment options.
Yeah, his question is about why is penile bulb exposure rarely mentioned when receiving radiation to prostate? I don't know if it's rarely mentioned. It's something that at the Proton Center, and I suspect this is true with IMRT as well, that the penile bulb is contoured as an avoidance structure on all of our patients. We try to reduce the radiation dose to it. The reason, of course, being that there are data suggesting that dose to penile bulb is one of the many factors that can determine the possibility of developing subsequent erectile dysfunction. So, you know, it's a routine part of a plan. I don't know how much time I spend telling the patients about it, but we do look at it in everybody that we treat. Do you get less penile bulb exposure with protons? Generally, you do. Again, it depends on the patient anatomy. It depends upon the plan arrangement. That you can do comparative plans, and you often will see a difference. Sometimes it's a major difference. Sometimes it's not that significant.
We have more of a technical question. When will this presentation be available on YouTube? I know it's live streaming right now, and I think it actually will be available even later today. John, you could probably add more on that.
Yeah, it needs to go through the editing process. It will be up tomorrow, definitely.
Okay. Yeah, and I think, John, you had a question here. Back. What's the best type of imaging today? Dr. Almeida, I think, who's over in Phoenix, was he? He's no longer treating patients. So what type of imaging and where?
Carl, do you want to take this one?
Yeah, sure. I know, yes, but Dr. Almeida, who I know, and I think many of us here know, was involved with doing this 11 acetate PET scan, which was an excellent imaging modality. Unfortunately, because of the technical limitations of manufacturing C11 in the very short half-life, that's no longer being used. There is one approved PET scanning agent currently for prostate cancer, and that would be the fluocinolone or Oxymin scan. There are two that are in investigation in the United States, the gallium-68 PSMA, and then there's another F18 based one that I never quite pronounce, DYPECL or something like that, which, at least if you read the papers, those two investigational agents have a much higher sensitivity and specificity for prostate cancer than F18 Oxymin. And we've been hearing now for the last 2 years that their approval is always 1 year away, which it'll be nice when either one gets approved, because both gallium-68 PSMA and especially the F18 based agent that Stanford's working on are going to be readily available, as opposed to needing a dedicated cyclotron to manufacture the isotope like C11 acetate. So we'll be able to do these scans when they're approved. We have a PET CT at the Proton Center, which we use a lot. We'll use it even more. And as I mentioned, during my talk, it's not just one imaging modality that you like to use. You want to get these composite pictures, and putting 2 or 3 imaging modalities together is not unusual at all. PET CT is fantastic for showing lymph node involvement, especially things that are well away from the prostate. If you're looking at the prostate gland itself, multiparametric MRI it's really opened my eyes. I've treated as a lot of people 29 plus years now doing proton therapy, and I wish I'd had multiparametric MR for 28 plus of those years. You can just see so much more. But the real key is not only having these various imaging modalities, but using them to generate a composite target of what you want to treat. And that's not just in prostate cancer. We do this in the vast majority of things that we treat in the human body now. We use combinations of CT PET, CT MR PET, etc.
Great, thank you.
And I just wanted to put a plug in for a whole body MRI trial that we have going on at UCSD.
Absolutely. Yes.
It is, we have a novel MRI technology that was developed there called RSI, and it's a way of looking at the nuclear density of the cells in a particular tissue. So it's been shown to be really effective for determining the extent of a prostate cancer in the prostate, and also sometimes for telling us the grade in a patient who hasn't been biopsied, or in a patient who's Gleason 6 on active surveillance. Sometimes we'll find these really ugly looking lesions in their prostate on RSI, and then we biopsy that, and lo and behold, it's a Gleason 9. So this RSI technology, we are investigating the use on whole body. So we could perhaps find small deposits of cancer in the lymph nodes or in the bones. And so it's a clinical trial. You can't just call in and order one. I can't order one, but I can, if you see me as a in consultation, I can order it. I think, Carl, you can probably put patients on it too. So
Definitely.
Any of us that you see, we can get you on the whole body MRI trial. I think if you're Gleason 6 and nothing else, you're probably not a candidate because they're very unlikely to find anything, but it's in patients with higher risk or metastatic disease.
Yeah, I was part of that RSI a couple of years ago, and they did find, I can't even remember now whether it was 2 or 3 lymph nodes that were involved that, my PSA at the time was, I think, 0.1, between 0.1 and 0.2. And so it's just remarkable that it's able to identify that at such a low PSA level. Yeah. So yeah, we're very lucky that we have such great diagnostics, mostly still being adopted just in the last 3 years. Certainly my surgeon did not have me have an MP-MRI 3 years ago. Otherwise, it sounds like surgery was not the preferred method for me. Last question we have online. Could you compare the results of brachytherapy to proton beam therapy?
Yeah, so there are no direct comparisons of brachytherapy to proton beam. I think we can do with either one what we call dose escalation, which means give high doses to the prostate or high doses to the tumor in the prostate. But I will tell you just from my experience, I've been doing brachytherapy for 25 years, and I firmly believe it's the best treatment option for younger guys who want to maintain sexual function with low risk or unfavorable or favorable intermediate risk, not unfavorable, favorable intermediate risk prostate cancer. That means Gleason 3+4, Gleason 3+3. Patients who want to have treatment, we can give incredibly high doses with brachytherapy, cure rates approaching 95%. And for those patients, I tend to prefer it. I don't know if you have a comment on that, Carl.
Yeah, I mean, first of all, I totally agree. I think that brachytherapy is a fantastic way to treat low and intermediate risk prostate cancer. The numbers that you see, the freedom from relapse and the preservation of sexual function are as good as anything else out there, if not better. There is, as John mentioned, there has not been a randomized comparison of the two. There are a number of non-randomized comparisons. There's one that you do a literature search, my name will pop up on, from about 2008, where at that time, we had done a randomized trial of dose escalation, a 2-institution study, Loma Linda and Harvard, and this was based upon using protons to dose escalate. And we then did a comparison of the biochemical freedom from relapse of the low-risk patients who were in the high-dose arm of that trial to similar patients who underwent brachytherapy at Mass General, primarily by Anthony Zeitman. And when you looked at their biochemical freedom from relapse at 10 years, it was equivalent. It was very high either way. So, I mean, that just speaks to the fact that with any of these methods, if you get a high dose into the target and you've got favorable disease, you're very likely to eradicate it. But for, if you talk about what is going to be the lowest radiation exposure to a patient, that's going to be brachytherapy. Because you're putting in internal sources, you're not going to have dose all the way out, appreciable dose all the way out to the skin. So that's another potential advantage of it. It's an excellent treatment. I think that the biggest downside to brachytherapy is that there are just fewer and fewer people who are adept at doing it for a number of reasons. I don't know how many, John, what you've seen here over the last last decade or so. My impression has been that the number of practitioners that do it routinely it's just dropped dramatically.
It's true. Across the country, I think IMRT technology in the early 2000s kind of took over, and many people stopped doing brachytherapy and switched to IMRT. Not because brachytherapy doesn't work, but because there's I hate to say it, but there's a financial incentive for treating patients with 8 weeks of IMRT. It pays way more. But there are still many of us across the country that continue to offer brachytherapy to our patients, either low dose rate, which is the permanent seeds that I do, or high dose rate, which you could get at UCLA or Cedars or UCSF. Both are again different tools and different ways of kind of doing the same thing. There's a question here that has a brachytherapy component. What do you think of UCSF's Dr. Mac Roach using SBRT to replace HDR plus IMRT? Well, I think many people many centers have replaced the use of brachytherapy with SBRT or IMRT, as I talked about. And it's not necessarily, and in most cases isn't, about effectiveness of one over the other. I think there are believers in SBRT. People who have bought CyberKnives tend to be big believers in SBRT because that's the only thing that you can do with a CyberKnife. But others are strong believers in SBRT as well. I will tell you, UCLA has both. They do both very commonly, SBRT and the use of HDR with IMRT. And I think that they both probably work quite well.
Great. John, did you have any other questions or questions from the other platforms?
I have no other questions from YouTube. And the doctor answered my question, which I was going to ask, so I'm good on my side.
All right, excellent. Well, I think we've answered everything. Last call for questions out there. If anyone would like another question for Dr. Einck or Dr. Rossi. But myself, wow, I certainly learned quite a bit from you guys. This was, I think, the first time I've heard a good presentation on proton therapy, as opposed to, I think, just a marketing slide or two online or something. Certainly have opened our eyes, I think, to the technology. Thank you so much for your time today. Oh, we do have a new question. Can you provide an estimate of the proton treatment costs? And a lot of our people out there, of course, are on Medicare. Although, myself, I'm still on private insurance. So are there any differences in light of that either?
Yeah, I was happy to take that. So when you talk about the cost of radiation therapy, there are two components that come into the cost of any one plan. There's the professional component, which is the physician services, physics services, all those things. That's typically around 10 to 20% of the total cost of treatment. And then you have what's called the technical component, which is the actual daily delivery charge. So if you look at proton treatment of anything versus, say, IMRT, the professional charges are generally identical. There's no difference because we do the same planning either way. We're doing, we're going to generate some similar type of physics plan. We're going to do the same type of imaging in advance. Where there currently is a difference is in the cost of the technical component, the daily treatment delivery. And now, realize that when we talk about cost in the medical world, there's contracting. You can charge whatever you want, but you're going to get paid what your contract says you're going to get paid. So you'll see people quote numbers that are just totally out of touch with what is the reimbursement reality. But if you look at Medicare, and you look at what Medicare pays for one fraction or one treatment of protons, typically Medicare right now is paying around $1,100 per fraction of proton treatment, whereas they pay about half of that for one fraction of IMRT. And that's where the difference in cost lies. It's the difference in the technical delivery. That's not going to last forever, partly because people, insurers, and even CMS is not going to maintain that forever. And what we need to get to in the proton world to make a lot of these insurance denials go away, we need to get to a point where the cost of the treatment delivery, that technical cost, is virtually identical to what it is for IMRT. And one last thing on that subject, back when the Proton Center was still part of Scripps, and I think this is, we're looking at this again, of course, we had contracts with 2 major insurers here in California where the payment for protons of treatment of prostate cancer and the payment for X-ray therapy of prostate cancer was the same. And once we had those contracts in place, all of a sudden my headaches with those 2 insurers in terms of writing letters of medical necessity and doing comparative plans and all this other stuff went away, because from the insurer standpoint, and they made it quite clear, their opinion was, yes, we know the treatment works, we think it's equivalent to X-ray therapy, we just don't want to pay more for it. So once you got them to the point where the cost was the same, then they figured, we're writing the same check, you guys do with it what you want. Last thing on the subject is that, people will often ask, well, what's going to cost me if I go to a proton center, my insurance denies me, what do we charge? Again, you're going to see numbers all over the place from the different proton facilities in the United States. The tack that we've taken here in San Diego is that for U.S. citizens who are not of Medicare age, in essence, we charge the Medicare rate to do the treatment. So that will give you some idea of what the cost would be.
Gotcha. Thanks for that. Another question that just came in: can you not use IMRT machines you have to do SBRT?
Sure. You can use IMRT to do pretty much anything. The point I was making is you can't use a CyberKnife machine to do anything but stereotactic treatment.
All right. Okay. I think that's all of our questions for today. Yeah, thank you so much for your time. We certainly do appreciate it. And I'm certain we're going to be asking to have you guys back sometime in the future for even more updates on proton therapy.